Ladies and gentlemen, please welcome the American Heart Association's Chief Executive Officer, Nancy Brown.
Welcome to Orlando and the American Heart Association's Scientific Sessions 2015. We are honored that you are here. Everything you experience at Scientific Sessions reflects our shared commitment to accelerating the advancement of science. Over the next 4 days, you will have the opportunity to observe, discuss, and share the very latest developments in cardiovascular and stroke research. There is a famous quote by Calvin Coolidge, 30th President of the United States. This says, "No person was ever honored for what he received. Honor has been the reward for what he gave." Every day, the generosity of philanthropists helps visionary scientists and researchers turn their ideas into new breakthroughs for humanity. Today, I'd like to give special thanks to two such philanthropists who are helping the American Heart Association accelerate science. David and Stevie Spina of Wayland, Massachusetts, built on their powerful legacy of philanthropy earlier this year with a $2.5 million gift to support the American Heart Association's Institute for Precision Cardiovascular Medicine. Their gift has made it possible for us to create the Institute's Grand Challenge Prize Initiative, a first in the history of the AHA. Sally and Bill Soder of Palm Beach, Florida, donated $5 million in May to create the Sarah Ross Soder Center for Women's Cardiovascular Research. This remarkable gift will enable the American Heart Association to devote the next 4 years to examining key questions surrounding the causes, risk factors, and most effective treatments for cardiovascular disease in women. It's a privilege to work closely with philanthropists like the Spinas and the Soders. I am also very pleased to announce an exciting new partnership between the American Heart Association and PCORI, the Patient-Centered Outcomes Research Institute. Together, we will harness the power of crowdsourcing to build a research platform, generating the most innovative, compelling ideas for cardiovascular comparative effectiveness research. We will seek the wisdom of thousands of patients, family caregivers, clinicians, and researchers to create a prioritized list of research questions. We'll seek input on key gaps in our knowledge about which prevention, diagnostic, and treatment approaches work best for which cardiovascular patients based on their needs. We are grateful to Dr. Joe Selby, Executive Director of PCORI, who is with us today, and its Board of Governors for their incredible vision and collaboration. We look forward also to your ideas as part of our crowd. Finally, I'm pleased to announce today that we are launching a new national campaign called Target BP. Together with the American Medical Association, we will help healthcare providers and patients achieve better blood pressure control at levels optimal to improve health outcomes. A meeting of this caliber would not be possible without the outstanding work of the American Heart Association's Committee on Scientific Sessions program. The committee is led by Chairman Dr. Frank Selke of Brown University Medical School and Rhode Island Hospital and Vice Chairman Dr. Eric Peterson from the Duke Clinical Research Institute. Will you please join me in a round of applause for Dr. Selke, Dr. Peterson, and the entire Committee on Scientific Sessions program. And now it is my honor to introduce Dr. Mark Creager, President of the American Heart Association. Dr. Creager is Director of the Heart and Vascular Center at Dartmouth-Hitchcock Medical Center and Professor of Medicine at the Geisel School of Medicine at Dartmouth in Lebanon, New Hampshire. During more than 30 years of volunteer service to the American Heart Association, he has made countless enduring contributions to our mission of building healthier lives free of cardiovascular diseases and stroke. Please welcome Dr. Mark Creager.
Thank you, Nancy. On behalf of the American Heart Association and American Stroke Association, I'm privileged to welcome this esteemed group of scientists, healthcare providers, educators, and trainees from all over the globe. Thank you for joining us, and thank you for all the work you're doing to save and improve lives. Today, I'd like to talk to you about the burden of vascular disease and the urgent reasons we must act to preserve vascular health. As a specialist in vascular medicine, I've devoted my career to investigating vascular diseases, and most importantly, to caring for patients with these disabling and often fatal conditions of the arteries and veins. The importance of the vascular system was noted some 2,500 years ago by Hippocrates, when he made this observation about the blood vessels. They are the sources of human nature and are like rivers that purl through the body and supply the human body with life. It's a compelling metaphor. Rivers are sources of life, vitality, and connectivity. When a river becomes obstructed or damaged, everything around it suffers, sometimes with grave consequences. The same occurs with the rivers and tributaries that are our blood vessels. When they are damaged, everything downstream is in peril. That's precisely the problem millions of Americans are facing today. Their damaged vessels put their bodies in dire jeopardy. Just over a century ago, William Osler said, "Life's tragedies are usually arterial." And indeed today, two significant vascular disorders, atherosclerosis and thrombosis, are the principal underpinnings of the two leading causes of death in the world, heart disease and stroke. These disorders also cause peripheral artery disease, which affects between 8 and 10 million people in the United States. Peripheral artery disease, also known as PAD, limits a person's ability to walk, may require revascularization, or worse yet, can result in the loss of a limb. But PAD is not simply a disease of the legs. It's a clinical manifestation of a systemic disease, often associated with heart attacks, strokes, life-threatening kidney and intestinal problems, and other serious health issues. Tragic outcomes can also occur when veins are affected. Up to 600,000 people are affected by venous thromboembolism each year. It's the cause of death of over 40,000 people. And the burden of vascular diseases goes beyond lives lost and changed. There's also a fiscal toll. Cost in this country for vascular-related complications in patients with PAD is more than $20 billion a year. Healthcare costs for venous thromboembolism exceed $7.5 billion. Clearly, the unrecognized epidemic of vascular disease requires our attention. And that's why I'd like to focus not only on the extent of this crisis, but also the importance of using what we know to treat it and prevent it, and the urgency of intensifying our research efforts to better understand it. For me, vascular disease is personal. My father, Nathaniel Creager, suffered from PAD, possibly due to decades of smoking. He grew up when smoking was the norm, and even encouraged by some physicians. It was a lot like the hit TV series Mad Men, with everybody lighting up everywhere all the time. My dad fired through 3 packs of unfiltered Chesterfields a day for over 30 years. He quit when he was 50, about 10 years after the Surgeon General's landmark report on smoking and health. But by age 62, he had developed increasingly severe leg claudication and then severe hypertension caused by renal artery stenosis. Yet we were fortunate. My father had access to quality care and a son who recognized his symptoms and sent him to physicians who understood the disease. They helped him live a fulfilling and independent life with my mother until he died just last year at age 91. While we were blessed with his extra years, the disease left its mark. His legs fatigued easily. He developed renal failure and endured dialysis for more than 5 years. Truly, my father illustrates both the struggle of living with PAD and the benefit offered by diagnosis and treatment. My father was one of over 200 million people across the globe affected by PAD. The disease is prevalent not only in high-income countries, but in low and middle-income countries as well. And it affects both men and women. Importantly, the risk of PAD is increased by tobacco use, diabetes, and high cholesterol, and prevalence increases dramatically as we age. PAD is also disproportionately present in some minority populations. For example, there is a greater prevalence in African Americans than Caucasians, which is consistent with the troubling fact that African Americans face an overall higher burden of heart disease and stroke. Socioeconomic factors also play an important role with PAD. When my colleague Rina Pandey and I investigated the U.S. National Health and Nutrition Examination Survey database, we found the highest prevalence among people in the lowest income brackets or with the lowest education levels. These findings were largely independent of traditional risk factors. Why is this important? Because the risk of death is at least doubled compared to patients who do not have PAD. And the risk of cardiovascular death, myocardial infarction, stroke, and hospitalization among people with PAD exceeds that of patients who already have had a heart attack or established cerebrovascular disease. Yet PAD is a health crisis that is largely unnoticed. One survey found that 75% of the public is unaware of PAD. This is highlighted by a Wall Street Journal story in which a 71-year-old retired social worker in Minnesota described the excruciating pain in his leg this way. I thought it was a bad Charlie horse, so I sat down to have a smoke, and the cramps went away. Even physicians often fail to consider PAD, chalking up leg pain to age or arthritis. In one study, physicians missed the diagnosis of PAD half the time. And even when physicians diagnose PAD, they often don't treat it adequately. When my research group examined the NHANES database, we found risk factor modifying therapies and antiplatelet drugs were being prescribed for fewer than 30% of PAD patients who do not have previously established coronary or cerebral vascular disease. This oversight is not trivial. When studied in patients with PAD, antiplatelet drugs and statin therapy each reduced the risk of heart attack, stroke, and cardiovascular death by approximately 25%. Among symptomatic patients, therapies such as supervised exercise training can double walking distance. This option is not considered if the diagnosis is missed, and it's rarely instituted even with the diagnosis, largely because of a lack of reimbursement. Let me illustrate what a difference supervised exercise can make. One of my middle-aged patients was putting in 30 minutes a day on the treadmill and doing quite well. Her conditioning improved so much that she was able to spend 6 hours per day over several days at Disney World right here in Orlando with her 5-year-old granddaughter. In a letter to me afterward, she called it the most wonderful vacation of my life. She said, "The joy of seeing her granddaughter's face light up was well worth all the hours I have spent exercising." She summed it up by saying, "Thank you for giving me back the will to continue walking." It was one of those moments we are all grateful for, when we see our work change people's lives. It is moments like those that underscore our need to address vascular diseases. Indeed, our ability to diagnose and treat vascular diseases has never been greater. The field of vascular biology has virtually exploded in recent years. Our understanding of the pathophysiology underlying atherosclerosis and thrombosis is being translated into novel therapies for prevention and treatment. The application of genomics and proteomics to the development of more precise therapies is being realized. Consider the promise of the PCSK9 inhibitors. These drugs evolved from the recognition of a genetic mutation in families predisposed to hypercholesterolemia and premature atherosclerosis. This led to a better understanding of a protein involved in regulating LDL cholesterol levels by targeting the liver's LDL receptors for degradation, and from there to a fragment of a monoclonal antibody to block that protein and dramatically lower LDL cholesterol. Similarly, novel oral antithrombotic drugs to treat venous thrombosis and prevent pulmonary embolism have entered the marketplace, and new antiplatelet drugs have the potential to reduce limb complications of PAD. Advances in technology are also leading to innovative approaches with optical coherence tomography, intravascular ultrasound, PET-CT, and contrast-enhanced magnetic resonance imaging, and other modalities to image plaques and to assess their vulnerability for rupture. For more on this topic, I encourage you to attend Professor Keith Fox's Paul Dudley White International Lecture on Tuesday. Innovative bioengineering also is leading to the application of fenestrated stents to treat aneurysmal disease. And drug-coated balloons and bioresorbable vascular scaffolds hold the promise to reduce restenosis, preserve vascular patency, and improve outcomes following endovascular treatment of critical lesions. As you can see, there are many ways to treat vascular diseases, but we still have a long way to go in awareness, treatment, and prevention to preserve vascular health. And so we must continually seek new and creative solutions. We took a stride forward a few months ago when the American Heart Association convened a group of leading vascular disease experts to discuss ways to boost awareness and knowledge and to generate a roadmap for AHA initiatives to tackle atherosclerotic, peripheral vascular diseases, aortic aneurysms, and venous thromboembolism. The outcomes of this summit include plans for increased public awareness, improved professional education, enhanced quality initiatives to address vascular health on a large scale, and more. Our efforts to preserve vascular health must be considered early in life. In fact, endothelial function, a measure of vascular health, begins to decline well before the clinical manifestations of cardiovascular disease. In light of Robert Furchtgott's Nobel Prize-winning identification of nitric oxide as an important vasodilator released from the endothelium, my group studied endothelial function in healthy adults by measuring the blood flow response to methacholine. We used the age range of 20 to 29 years old as a reference. Even by age 30 to 39, the age of many early career professionals in this audience, we saw a 30% decrease in endothelial function. For ages 40 to 49, about the age of mid-career professionals, the drop was 50%. And for people over 50, which includes many of us senior clinicians and scientists, the decline was even greater. Superimposed on the aging process, endothelial function is further impaired by smoking, high cholesterol, hypertension, and diabetes. And abnormal endothelial function precedes and contributes to atherosclerosis. The blood vessels also stiffen as we age. This phenomenon is linked to systolic hypertension, stroke, atrial fibrillation, and heart failure. Mechanisms responsible for increased vascular stiffness and the underlying changes in the structure of the blood vessel wall include abnormal amounts of collagen, elastin degradation, and vascular smooth muscle infiltration. Importantly, excess sodium intake and elevated blood sugar contribute to increased vascular stiffness. And on the other hand, regular exercise can reduce stiffness. Considering the importance of improving these health factors, the American Heart Association has set a goal of improving the cardiovascular health of all Americans by 20% and reducing death from cardiovascular diseases and stroke by 20% by the year 2020. The World Health Organization is also working to reduce premature deaths from non-communicable diseases, including cardiovascular diseases, by 25% by the year 2025. Addressing vascular diseases is a critical component to reaching these goals. The good news is we are making progress. Through the first half-decade of work toward the AHA's 2020 goal of a 20% drop in cardiovascular disease deaths, we've already seen a decrease of 13.7%. People are living longer, and the 75 million people in the baby boomer generation are projected to see an average lifespan of 83 years. But what will that extended lifespan look like? Will we have more good years or just more years? The concern is whether we will suffer from difficulty walking, congestive heart failure, stroke, and dementia, all of these resulting from vascular disease. To help people age successfully, we must put forth bold initiatives to benefit vascular health and consequently our hearts, our brains, and our limbs. One way the American Heart Association is doing this is by firmly embracing the concept of building a culture of health. This simply means creating environments where the healthy choice is the easy choice. We believe we can make a difference by helping people make healthy decisions wherever they are, at work, at school, at home, and at play. We're building this culture on a number of fronts. We are advocating at the national, state, and local levels, and we're helping communities address their specific health needs. The AHA is fighting tobacco through support of taxes on cigarettes, clean air laws, and easier access to smoking cessation programs. In addition, the AHA strongly opposes marketing campaigns promoting electronic cigarettes to youth. The AHA is also making it easier to find healthier food and drink options. We're advocating for a healthier food supply, including reduced sodium content, lower saturated fat and trans fat, and for improved nutrition in schools. A culture of health means healthy choices are affordable and available for everyone. That's why the AHA is encouraging innovative community development in low-income areas, more access to healthy foods, and safe places to exercise. And as suggested in a recent American Heart Association scientific statement on the social determinants of risk and outcomes, we must address health disparities by developing strategies that are linguistically and culturally sensitive. A culture of health is necessary at work too, because people spend so much time there. So the AHA is helping companies by encouraging comprehensive workplace health programs. And finally, a culture of health is one where everyone has access to high-quality health care. The Affordable Care Act is helping more people get insurance, and the AHA's quality improvement programs are helping healthcare providers ensure the proper standard of care. Our healthcare system is also striving to meet people where they are through ancillary systems of care using digital technology. At the Dartmouth Hitchcock Medical Center, we are initiating a program with a leading technology company in which patients' data can be gathered using biometric sensors, instantly sent to the cloud, and continuously monitored by healthcare professionals. Critical treatment adjustments can be made promptly without the patient ever leaving home. Innovations in digital technology are also transforming the way we conduct science, with new opportunities to acquire, analyze, and interpret big data. I'm looking forward to hearing more about this important topic later in this session from our Connor lecturer, Dr. Andrew Conrad. While it's exciting to witness these tremendous advances, we're not seeing enough clinical research in vascular diseases. Consider this. Of the nearly 41,000 interventional trials registered in clinicaltrials.gov in a 3-year stretch ending in late 2010, fewer than 700 involve peripheral vascular diseases. That's less than 2%. Research funding is crucial, which is why the AHA funds more cardiovascular disease and stroke research than any U.S. organization outside the federal government. This past fiscal year alone, we funded nearly 1,000 new projects and increased our funding to $145 million. The AHA also continues to push ahead with new research initiatives, such as our Institute for Precision Cardiovascular Medicine. The research funded by the Institute integrates the precision of molecular analysis into long-term population studies to increase our understanding of cardiovascular health and disease and direct us towards better targeted, safer, and more effective treatments. And we're funding strategically focused research networks on prevention, hypertension, disparities in cardiovascular disease, and cardiovascular health in women. The American Heart Association also strongly supports the National Institutes of Health. And I encourage all of you to attend tomorrow's presentation from Dr. Gary Gibbons, Director of the National Heart, Lung, and Blood Institute. Like many of you, I'm grateful for the funding I receive from both the AHA and the NIH. Sadly, research funding for the NIH continues to decline in terms of real dollars. So I urge all my U.S. colleagues to advocate for more federal research support. It's also critical that we advocate for a healthier environment and for improved systems of care. One impactful way you can do all of this is to join the AHA's You're the Cure network. For our international colleagues, consider working with health organizations like ours in your own country. Earlier, I discussed Hippocrates comparing blood vessels to rivers that supply life to the human body. As you leave here today, and as you navigate sessions this week, I ask each of you to remember that imagery of a journey down a vibrant river. All of us are on this journey of life, but you, here in this room, are uniquely qualified to change that journey for so many people, to save and improve lives. I challenge you to make a difference for others sharing this journey. Use your skills, knowledge, and influence to help our patients, families, friends, and colleagues improve their own vascular health, to find their way to a culture of health, and to enjoy richer, fuller lives. Thank you, and enjoy the meeting. Now, I'd like to introduce the chairman of the American Heart Association, Al Royce.
Thank you, Mark. The Chairman's Award honors individual excellence in volunteer service that significantly advances the association's strategic goals. This year's recipient is Dr. Timothy Gardner, Medical Director of the Center for Heart and Vascular Health and Executive Director for the Value Institute for Christiana Care Health System in Newark, Delaware. For 3 decades, Dr. Gardner has played a critical role in the American Heart Association's priority planning, programming, and governance at virtually every level. Among his many leadership roles, he served as AHA President in 2008-2009. He is a past chairperson of the Association's Committee on Scientific Sessions program, a past member of our Board of Directors, and based on his vast expertise as a cardiovascular surgeon, he was elected to represent us as a member of the American College of Cardiology, American Heart Association Task Force on Practice Guidelines. In fact, he was the first surgeon ever named to this task force. Dr. Gardner is admired throughout the association for his passion and his commitment to advancing our mission of building healthier lives, free of cardiovascular diseases and stroke. He has contributed his time and energy on our behalf in countless ways, including as a media spokesperson, as a guest editor for our journal Circulation, as a member of the writing team that created our 2008 Principles for Healthcare Reform, and as a leader with several of our scientific councils. Year after year, his stellar example of volunteer dedication has been an inspiration, and that is why it is my pleasure now to welcome Dr. Tim Gardner as the recipient of the 2015 Chairman's Award. Dr. Gardner.
Colleagues and friends, I'm honored and very grateful to receive this award. In particular, I thank our chairman, Al Royce, for this recognition. But I accept the award on behalf of the many dedicated and deserving volunteers and donors who do so much and give so much of themselves in support of the work of the American Heart and Stroke Association. For many of us professional members here today, the Heart Association has provided numerous opportunities and direct support for our careers through scientific sessions and other professional meetings, through participation in science councils, by funding our research, by clinical guidelines development, and through many other science programs. And while we are very important to the mission of the association, we science volunteers represent only one part of this outstanding organization. There are hundreds of thousands of Heart and Stroke Association volunteers who participate at national, affiliate, and community levels. These volunteers, working with Heart Association staff throughout the country, provide the critical financial support and personal engagement in our causes, without which the Heart and Stroke Association would not be so successful. The association also is blessed with talented and committed staff, again at many national, affiliate, and community sites, dedicated individuals who really live for Heart Association goals that all of us share. For these individuals, the AHA isn't just a job, it is a cause. So I accept this Chairman's Award for many Heart Association friends and colleagues, and for the thousands of lay and professional volunteers who sustain the mission of the association through their commitment to AHA in the U.S. and throughout the world. Thanks to all of you for your generosity and active participation in the work of the American Heart and Stroke Association. Because of you, together, we will continue to succeed in building healthier lives, free of cardiovascular diseases and stroke. Thank you.
Congratulations, Dr. Gardner, and thank you, Al. Each year, the association confers the Distinguished Scientist designation on members whose innovations have led to far-reaching implications in the field of cardiovascular and stroke research. Let's take a look at this video highlighting 6 outstanding and groundbreaking careers.
The American Heart Association and American Stroke Association's distinguished scientists are a select group of investigators whose innovations have had far-reaching implications in the field of cardiovascular and stroke research. This year, we honor 6 such forward-thinking individuals and their seminal contributions to their fields. The 2015 Distinguished Scientist honorees are Samuel Z. Goldhaber, M.D., FAHA, Professor of Medicine at Harvard Medical School, Section Head Vascular Medicine, Director of the Thrombosis Research Group, Cardiovascular Medicine Division at the Brigham and Women's Hospital in Boston, Massachusetts. Dr. Goldhaber is a clinical trialist whose work has led to significant advances in the fields of pulmonary embolism, deep venous thrombosis, and stroke prevention in individuals with atrial fibrillation. His original research has included approaches to venous thromboembolism that have elucidated the pathophysiology, improved the detection and diagnosis, enhanced risk assessment and prevention, and advanced treatment. Dr. Goldhaber published the first randomized trial of thrombolytic therapy in patients with pulmonary embolism, showing improved right ventricular function in those treated with thrombolysis. This publication laid the groundwork for the next phase of advanced therapies for pulmonary embolism. He also established the importance of obesity, cigarette smoking, and hypertension as risk factors for this important problem. He developed an electronic alert system which prompted clinicians to utilize prophylaxis in hospitalized medical patients against venous thromboembolism and reduced the rate of subsequent pulmonary embolism and DVT. Dr. Goldhaber's overall contributions to our knowledge of venous thromboembolism diagnosis, risk assessment, prevention, and treatment have been profound. Mark Allen Pfeffer, M.D., Ph.D., FAHA, Zhao Professor of Medicine at Harvard Medical School, and Senior Physician, Cardiovascular Division, Brigham and Women's Hospital, Boston, Massachusetts. Dr. Pfeffer's impressive contributions comprise one of the most inspiring bodies of work in what is now called translational research. Dr. Pfeffer, along with his late wife, Dr. Janice Pfeffer, and Dr. Eugene Brownwald, is credited with introducing the concept that angiotensin-converting enzyme inhibitors could attenuate adverse ventricular remodeling following myocardial infarction, and that their use would result in prolonged survival and other clinical benefits. Since this initial discovery, he has had a principal role in many practice-changing clinical trials, such as SAVE, CARE, Valiant, CHARM, PEACE, ARISE, TREAT, Altitude, RED-HF, TOPCAT, and ELIXA. An internationally recognized expert in the field of cardiology, his work spans the spectrum from enhancing our understanding of basic pathophysiologic concepts to defining evidence-based therapy, a classic example of a career devoted to expanding our knowledge from bench to bedside. Barbara J. Riegel, Ph.D., RN, FAHA, Edith Clemmer Steinbright Professor of Gerontology at the School of Nursing, University of Pennsylvania, Philadelphia, Pennsylvania. Dr. Riegel's seminal work includes her development and rigorous testing of the Self-Care of Heart Failure Index, the first instrument to comprehensively measure self-care in patients with heart failure. The measure is now considered the preeminent measure of self-care in heart failure, has been translated into 16 languages, and used in more than 30 countries around the world. Recently, Dr. Riegel's work in theory and measurement has extended to other cardiovascular diseases, including chronic angina and hypertension. Dr. Riegel is the international thought leader on the self-care of heart failure, and her research has made significant contributions to improving the health and quality of life of patients with heart disease worldwide. Howard A. Rockman, M.D., FAHA, Edward S. Orgain Professor of Cardiology, Professor of Medicine, Cell Biology, and Molecular Genetics, Duke University, Durham, North Carolina. Dr. Rockman pioneered the use of the mouse as a model system by developing miniaturized technologies to study murine cardiac pathophysiology. This work laid the foundation for the scientific community's use of genetically engineered mice to study molecular mechanisms of cardiac disease. In a landmark study, his work resulted in a paradigm shift in understanding how the heart responds to pathological stress. Recently, he discovered how beta-adrenergic and angiotensin receptors in the heart can be selectively activated to induce cardioprotective signaling, which has contributed to the development of a new class of drugs known as biased ligands. Dr. Rockman is an internationally recognized basic scientist whose research has provided the basis for multiple translational discoveries in cardiovascular disease. Jeffrey Saver, MD, FAHA, Director, Comprehensive Stroke Center, Professor and Senior Associate Vice Chair of Neurology at the David Geffen School of Medicine, UCLA, Los Angeles, California. Dr. Saver's research has been at the forefront of the treatment and care of stroke patients for over 20 years. He worked tirelessly to establish the concept and the reality of a stroke center without walls, unique in its ability to integrate clinical and research activities across multiple disciplines and departments. His studies were essential to the development and the implementation of stroke therapies, including clot-busting drugs and innovative devices. He is also responsible for modernizing the definition of transient ischemic attack, for developing methods to analyze the full range of post-stroke deficits in clinical trials, for extending stroke research to the pre-hospital setting, and for developing and testing clot retrieval devices to reopen cerebral arteries in acute stroke. Dr. Saver's work has gone well beyond designing, conducting, and leading groundbreaking, cutting-edge clinical trials to having a major impact on trial methodology and analysis to the great benefit of stroke patients. Russell P. Tracy, Ph.D., FAHA, Professor of Pathology and Laboratory Medicine and Biochemistry, Director, Laboratory for Clinical Biochemistry Research at the University of Vermont College of Medicine, Burlington, Vermont. Dr. Tracy has spent his career seeking to translate the molecular, genetic, and cellular basis of coagulation, fibrinolysis, and inflammation to provide a better understanding of the importance of these factors in atherosclerotic cardiovascular disease and in aging, to the particular benefit of middle-aged and older populations. His high-impact publications have made major contributions to our understanding of the role of inflammation in atherosclerosis and as a major cause of cardiovascular disease and non-cardiovascular disease morbidity and mortality in otherwise well-controlled HIV-infected individuals. His work with high-sensitivity CRP laid the groundwork for many important recent and ongoing clinical trials. Russ Tracy is a unique scientific leader with both a deep understanding of pathophysiologic mechanisms and a thoughtful perspective on how to integrate these mechanisms into clinical and population-based research.
Now, we'd like to pay tribute to several cherished friends of the American Heart Association who passed away this year. Each person we are remembering made an important contribution to our goal of fighting cardiovascular diseases and stroke. The impact of their work will live on. As their names appear, please pause for a moment of silence.